Dr. P.C. Rath, SVG Interventions.
Good afternoon, everybody. And we had a beautiful talk by Dr. Sharad Chandra demonstrating how to do a SVG PCI. And I'll be showing something where we were unable to do most of the recommendations which we had told us. Like we should do this precaution, we have to take adequate preparation and use a filter wire. Everything what he has told to do to get a proper result in a SVG intervention, we were unable to follow, and you will come to know why it all happened. And I'll start with this slide, which I saw in one of the talk on SVG by one of the beautiful speaker. What he said is that SVG intervention is like fighting in mud. To remain clean while fighting, it is almost next to impossible. So with that, I'll just start my presentation. This is a 46-year-old male. You can see he had got his CABG done 12 years back. That means when he was almost 34 years. He was a non-diabetic, non-smoker, non-hypertensive. And he presented to us with acute high lateral ST elevation MI. That is, he had ST elevation in 1 and AVL. Other leads were relatively normal. He had chest pain of almost 4 hours duration. So post-MI, acute MI situation, we thought we should go ahead with a primary PCI because he came to a center which is well equipped with primary PCI. And this is what the angiogram showed. You can see. This is the left shots. You can see the LAD has not a very critical lesion, but circumflex is totally occluded. And then we went to the right side. The right lesion looks pretty tight, ostial, completely occluded in the mid part. And then we had the shots for the graft. You can see this. The SVG to RCA is pretty normal. The lima was also patent in these patients. You can see the lima to LAD was patent, but the whole problem was in the SVG to OM. So this is the lima. Once again, just you can see this lima SVG to OM is completely occluded from the proximal part, and you can see the guiding. We tried different guidings, we were not getting proper support. Finally, with this M+ catheter, we were able to hook the OM and we took this shot. So at that point, the decision was what to do, whether we should go ahead with a primary PCI, put a wire, dilate with a balloon, or do what. But at that point, because you know it's a 12-year-old graft, so, and we were not seeing anything in the distal part. So we thought it's all full of clot, mud, and a lot of degenerated debris will be there. So it will be almost impossible to do a PCI without going with a distal embolization. So initially we thought that, okay, we'll go ahead and give this patient a fair trial of significant GP2B3 inhibitor. As Sharad Chandra sir told that GP2B3 are absolutely no, but this is one situation where GP2B3 I think should be tried, and that is what we tried. Along with GP2B3, we not only gave GP2, we also gave this patient thrombolysis because it was only 4 hours duration. So we gave him thrombolysis with tenecteplase also. And after half an hour, the patient continued to have pain. There was no resolution of the STs. At that point, we decided that thrombolysis, GP2B3 is not helping this patient. We have to go a little more aggressively in this patient. And then we decided, okay, now let us try and do PCI in this patient again. So at least the recommendation by Anuj, we followed judiciously that we should do adequate thrombosuction, and that is what we tried. You can see the difficulty with which the catheter is not going. So one shot we didn't show, we just used a small balloon, 2 mm balloon to dilate it a little bit, and then subsequently the export catheter was able to cross, and we took multiple runs. I don't know whether we have taken 7, 8 or 9 runs, but we didn't dilate with a bigger balloon, but we took multiple runs of export catheter, and You can see after that what was the result. You can see the whole graft is full of clots starting from beginning to end. Now where are we going to park our distal protection device? You can see the main artery is divided into three. Whichever place we want to put a distal protection device, I don't think we will be able to park anywhere. And the artery size, you see, it is very small. So there is no way you can put a distal protection device in this patient. What about proximal? There is no way where you can put a proximal also. Balloon occlusion also cannot be done. So we forgot that we have to use any distal protection or any of these devices. Yes, what we did is we put this patient on diltiazem was given 1 milligram, and then after giving diltiazem through the graft, then we went ahead with putting stents. And you can imagine how many stents we had to put. This is the first stent, short one, because we were very skeptical whether the stent will go or not. So we gradually started increasing the length of the stent. So this is the first stent. And then all three, we put in total all three stents. This is the, after putting the stent, you can see there is not much of distal, there is some slow flow, but not much. And this is the second stent, which is a little bigger, and you can see we are not over dilating, and you can see the size of the stent is just the size of the vein graft. We are neither overstretching or we are not going for any high pressure dilatation here. And this is the last one, which is the longest one, because we were sure that yes, the stents are able to cross properly, and then we put this third stent also. And this was the final result. You can see there is no distal embolization, the vessel is absolutely perfect, and the flow is TIMI-3 flow. So if we are able to prepare the lesion well, the take-home message here, I think what really led to improvement in the outcome in this patient was we gave this patient thrombolysis plus GP2B3A inhibitor. So probably that made the plaque little softer, and with the use of multiple runs of export catheter, probably the clot burden we were able to significantly reduce it, and we went ahead with direct stenting instead of going with pre-dilatation of the whole vessel and then put a stent. So all these things, precautions all those decisions which we took on the table probably helped in getting a good result, which probably I was never expecting when we started the procedure. Thank you very much.